senior faculty members and students. I welcome you all to the 19th undergraduate combined round of Mahatma Gandhi Medical College and Hospital. Today, the topic of UGCR is fibroid uterus, which will be covered by Department of Anatomy, Physiology and Obstetrics and Gynecology. The chairperson for today's sessions are Dr. Pankaj Kumar Singh Sir, Professor and Head Department of Anatomy, Dr. Aparna Garg Ma'am, Professor and Head of Department of Physiology, and Dr. Samta Bali Rathore Ma'am, Professor and Unit Head Department of Obstetrics and Gynecology of Mahatma Gandhi University of Medical Sciences. Now I invite Dr. Prateek Surain Sir, Assistant Professor of Department of Obstetrics and Gynecology, Mahatma Gandhi University of Medical Sciences and Technology, for introduction and brief comments on fibroid uterus.
Good morning, respected dignitaries, chairpersons, senior faculty members, my dear colleagues, and dear students. Talking about Leiomyoma, or what often we call as fibroid uterus, it is a very important topic because it is a very common condition which is prevalent in a female of reproductive age group between 30 to 50 years. Its prevalence is high as 30 to 50%. It comes with a varied kind of, although the very peculiar feature of fibroid is that most of the fibroids are, almost 75% of the fibroids are asymptomatic. But still, it is clinically very important because it presents with varied kind of symptoms like heavy menstrual bleeding, other menstrual irregularities, dysmenorrhea, infertility, and again a very high prevalence as well. It has got various wide range of treatment modalities available depending upon the age of the patient, location and size of the fibroid, and the desire of the patient for future fertility, and obviously the symptoms of the patient. So the treatment modalities range from medical management to minimal varied types of medical management, which will be discussed further, to minimally invasive surgeries, to surgeries, conservative surgeries and radical surgeries. So for us as a clinician, as well as you as a UG students, it is very important because you see the fibroid in a very daily practice, and it brings the amalgamation of various departments together, like Department of Anatomy, Pathology, Physiology, Gynae, Radiology, so that all of them cover the different aspect of this topic. So without further ado, I would like to call the speaker from the Department of Anatomy to please start the UGCR. Thank you.
Good morning to our esteemed dignitaries, honorable chairpersons, faculty members, and our fellow colleagues. I am Ayushi Sharma, and I will be presenting on the topic of anatomy of uterus. This presentation is prepared by Anushka Sharma, Sukhdev Patel, Suman Yadav, and Vaishnavi Devarwal under the guidance of Dr. Pankaj Kumar Singh, Professor and Head, Department of Anatomy, and under the moderatorship of Dr. Nahi Yasmin, Professor, Department of Anatomy. These are the learning objectives which we will be covering in our upcoming slides. Introduction, gross anatomy, embryology of uterus, histology of uterus, and the applied aspects related to it. The female reproductive system consists of a pair of ovaries, a pair of uterine tubes, the uterus, and the vagina. The ovaries secrete the female sex hormones, the estrogen and the progesterone, and also produces the female gamete, the ova. The uterine tube acts as a passageway between the ovary and the uterus. Uterus or womb is the site for implantation and also provides the suitable environment for the development of the fetus. Vagina is the fibromuscular canal which acts as the female copulatory organ. Now we'll be discussing in detail about the uterus. Uterus or womb is the pear-shaped organ located in the pelvic cavity of a woman. It is flattened anterior-posteriorly with its length as 3 inches, breadth at fundus as 2 inches, thickness as 1 inch, and it weighs around 30 to 40 grams. For the convenience of description, the uterus is subdivided into three parts: the fundus, the body, and the cervix. The fundus is the upper expanded dome-shaped part which lies above the horizontal axis, passing through the opening of the fallopian tube. The body is between the fundus and the isthmus, which is a narrow constriction that corresponds with the internal os. The cervix is the lower cylindrical part. Normally, the uterus lies in the position of anteversion and anteflexion. Anteversion is the angle between long axis of vagina and long axis of the cervix, and it is around the 90 degrees. The angle of anteflexion is the angle between long axis of body of uterus and long axis of cervix, which is around 120 to 170 degrees. For the means of better understanding, the relations of uterus can be understood under three subheadings: the body of the uterus, supravaginal part of the cervix, and the vaginal part of the cervix. Anteriorly, the body of uterus is related to the utrovesicular pouch. The supravaginal part is related to the posterior surface of the bladder, and the vaginal part of the cervix is related to the anterior fornix of vagina. Posteriorly, both the body of uterus and the supravaginal part is related to the recto-uterine pouch, and the vaginal part of the cervix is related to the posterior fornix of vagina. Laterally, the body of uterus is related to the uterine artery and the broad ligament. The supravaginal part of the cervix is related to the uterine artery and the ureter. One must keep in mind while ligating the uterine artery during the hysterectomy, as it is in close relation with the ureter. The vaginal part of the cervix is related to the lateral fornix of the vagina. The cavity of uterus is subdivided into two cavities: the uterine cavity proper and the cavity of cervix. The uterine cavity proper is a triangular shaped cavity. On its upper part and the posterior wall, the implantation occurs. The cavity of cervix is a spindle-shaped cavity which communicates with the cavity of vagina through the external os and the cavity of uterine proper through the internal os. The ligaments of uterus can be classified as true ligaments and the false ligaments. True ligaments are the fibromuscular bands which truly provide the support to the uterus. These include the round ligament, the pubocervical ligament, transverse cervical ligament, and the uterosacral ligament. The false ligaments don't provide the support to the uterus. These are the broad ligament, rectovaginal fold, the utrovesicular fold, and the rectouterine fold. The uterus is kept in the position and prevented from sagging with the help of supports of uterus. They can be classified as primary supports and the secondary supports. The primary supports include the muscular supports, which are the pelvic diaphragm, urogenital diaphragm, and the perineal body. The visceral supports include the urinary bladder, vagina, and the uterine axis, and the fibromuscular supports include the transverse cervical ligament, pubocervical ligament, uterosacral ligament, and the round ligament. The secondary supports include the broad ligament of uterus, utrovesicular fold, and rectovaginal fold. The uterus is mostly supplied by the uterine artery and partly by the ovarian artery. Ovarian artery is the lateral branch of abdominal aorta, and the uterine artery is the branch of anterior division of internal iliac artery. As the uterine artery ascends upwards, it divides into arcuate arteries. These arcuate arteries run transversely around the anterior and posterior surfaces of the uterus and then give branches to the radial artery. The radial artery supplies the myometrium. It gives branches to two sets of arteries, which are the basal artery and the spiral artery. Both of these arteries supply the endometrium. The basal artery supplies the basal zone and the spiral artery supplies the functional zone of the endometrium. The veins correspond to the arteries. The venous plexus is around the lateral body of the uterus, and they drain into the internal iliac vein. Lymphatic drainage of the uterus. The fundus and the upper part of the body drain into the pre- and para-aortic lymph nodes. The lower part of the body drains into the external iliac lymph nodes. As for cervix, it laterally drains into the obliterative lymph nodes and the external iliac lymph nodes. Posterolaterally drains into the internal iliac lymph nodes and posteriorly drains into the sacral lymph nodes. Nerve supply of the uterus. The sympathetic supply is derived from the T12 to L2, which causes the uterine contraction and vasoconstriction. The parasympathetic supply is derived from S2 to S4, which inhibits the contraction and causes the vasodilation. The visceral afferents are taken by two pathways. First, from the body of uterus, they follow the sympathetic pathway, and from the cervix, they follow the pelvic splanchnic nerves. The genital system consists of a pair of gonads, a duct system of gonads that carries the germ cells, and the external genitalia. They are developed from three sources: the intermediate mesoderm, part of cloaca, and the coelomic epithelium covering the intermediate mesoderm. The phenotypic expression depends on the SRY gene. The development of the genital system starts from 4th week of intrauterine life. Up to 5th to 6th week, the genital system remains undifferentiated. From 7th week, the development takes a different turn. In case of females, due to absence of SRY gene, there is regression of the Wolffian duct, development of the Mullerian duct or the paramesonephric duct, and the ovaries. The estrogen secreted by the ovaries stimulate the paramesonephric duct to develop the uterine tube, the uterus, and the upper part of the cervix, and also stimulates the development of the external genitalia. The paramesonephric ducts develop lateral to the mesonephric ducts, but when traced caudally, they cross the mesonephric duct from lateral to medial side, come close to each other, and fuse in the midline to form the uterovaginal canal. The paramesonephric ducts are open at its upper end, but when traced caudally, they come in contact with the dorsal wall of the phallic part of the urogenital sinus. The uterus develops from the uterovaginal canal. The primitive uterus consists of a body and a cervix. The body elongates and gets bigger than the cervix. The initial angular junction between the two paramesonephric ducts forms a convex dome-shaped structure known as the fundus. Histologically, the uterus has three layers: the perimetrium, the myometrium, and the endometrium. The perimetrium is the outermost layer formed of thin layer of connective tissue. It is subdivided into two layers, the mesothelial lining and the connective tissue. The myometrium is the middle layer and the thickest of all, formed of smooth muscle cells. They are arranged in three layers: outer longitudinal, middle mesh-like or irregular, and inner circular. The endometrium is the innermost lining formed of simple columnar epithelium, which also forms the tubular gland. The endometrium is divided or arranged in three stratas: the strata compactum, strata spongosum, and strata basale. The strata compactum is composed of neck of the glands. The strata spongosum is composed of areolar tissue, and the strata basale is a permanent layer which does not shed off during the menstruation and contains all the glands and the arteries. Now we'll be describing the changes in endometrium in different phases of menstrual cycle. In proliferative phase, the glandular epithelium proliferates. Therefore, the glands are tall and elongated, filled with thick colloidal substance, and the spiral arteries are also elongated. This phase is mainly concerned with the repair of the damage done during the menstrual phase. In the secretory phase or the luteal phase, the glands become highly elongated, coiled, and tortuous, filled with carbohydrate-rich-like substance. The spiral arteries are more coiled and tortuous. The layer becomes thick and edematous. During the menstrual phase, the strata functionalis sheds off and only strata basale remains. To summarize the differences or changes in endometrium during the proliferative phase and the secretory phase, we can refer to this table. The endometrial thickness in the proliferative phase is 3 to 4 mm, whereas in secretory phase it's 6 to 7 mm. Only strata basale is remaining in the proliferative phase, but all the three stratas are present in the secretory phase. The uterine glands are straight, long, widely separated with narrow lumen in the proliferative phase, whereas coiled, closely packed with wide lumen. Secretions in the proliferative phase are scanty secretions, but the lumens of the glands may be filled with secretion in the secretory phase. The spiral arteries are less coiled in proliferative phase, whereas more coiled and more tortuous in the secretory phase. The applied anatomy first is fibroids or fibromyas. These are the benign tumors of the endometrium, which clinically presents as hypermenorrhea and irregular contour of the uterus on bimanual palpation. Prolapse of the uterus occurs due to weakening of the supports of uterus, due to which the uterus comes out through the vagina. occurs during the tear of pelvic diaphragm during the childbirth. Endometriosis is presence of ectopic endometrial tissue outside the uterus. These commonly occur in the sites like ovaries or the ligaments of uterus. Endometrial cancer is the cancer of the endometrial lining or the inner lining of the endometrium. Thank you. Now I would like to call Ayushi Joshi to continue this presentation.
Good morning everyone, respected dignitaries, esteemed faculty members, seniors and dear colleagues. I am Ayushi Joshi from second prof year and I along with my team members Bhumika Kularia, Chavi Maheshwari, Himatri Gautam, Suhani Bansal are here to talk about the physiology of female reproductive tract under the guidance of Dr. Aparna Garg and the moderatorship of Dr. Premchand Rama. So the learning objectives of our today's presentation will be the physiology of reproductive system. Female reproductive system, we'll talk about briefly the ovaries, the fallopian tube, the uterus. Then we'll talk about the hormonal regulation of the uterus, where we'll be talking about how the estrogen and the progesterone have effects on the uterus. Then we'll talk about some uterine imbalance factors, specifically the fibroid uterus, what exactly is happening. We'll talk about the effects of imbalance, the fibroid uterus in brief, etiology of the fibroid uterus and some major differences between the normal uterus and the fibroid uterus. So let us begin by talking about the physiology of the normal uterus. So one thing we need to understand before starting is that the uterus, that is in a female's body, the uterus, its main function is to prepare itself for pregnancy. That is, it provides an environment for that embryo to grow. That's why we say that it is also involved in the menstrual cycle, obviously. We'll see in the later slides how exactly is the menstrual cycle taking place. One more thing that we need to understand is that there are three layers, as already talked about by the Department of Anatomy. There are three layers: the perimetrium, which is the serosa, outermost layer. It is protective in nature. It is a serous layer. Then we have the myometrium, which is involved in the contraction, specifically during the parturition as well as in menstrual cycle as well. Then we have the endometrium. So this endometrium proliferates and sheds cyclically and it responds to hormones such as estrogen and progesterone. You see that the estrogen is actually involved in the growth of this endometrial lining, while the progesterone helps in differentiating this proliferated endometrium. So it is actually acting as a stabilizing hormone. So now let's briefly talk about the physiology of ovary as well as the fallopian tube. So we know that ovary is mainly involved in oogenesis and additionally it is involved in the production, that secretion of a lot of hormones such as estrogen, progesterone, anti-Müllerian hormone, inhibin, etc. The fallopian tube is majorly involved in picking up the ovum for after ovulation. We know that this fallopian tube, it has four parts. Specifically, you can see that the fimbrium, this particular part of the endometrium is actually involved in catching the ova after the ovulation has taken place, and the ampia, which is another part of the fallopian tube, is actually the site of the fertilization. So this is the site of the fertilization. Now that we have briefly talked about all of this, we need to understand that menstrual cycle is basically the preparation of the uterus for the implantation. Now what we see here is that if the implantation will not take place if there is no fertilization, so if the fertilization has not taken place, then that endometrial lining is going to shed. When talking about the menstrual cycle, today we'll mainly focus on the ovarian as well as the uterine cycle, but there are vaginal cycle and the cervical cycle going on as well. So for this, we'll understand this with the help of this video. For this, we need to understand that when we're talking about the ovarian cycle, we have the two phases. We have the follicular phase as well as the luteal phase, and a cycle consists of 28 days. It can vary between 21 to 45 days as well. So on the first or fifth day, there would be menstrual shedding taking place. That is, the endometrial lining is going to fall off. Here, the estrogen and the progesterone levels are extremely low. So we can see that the menses are taking place in a female's body. From the 5th day to the 13th day, the pituitary gland is going to release the follicular stimulating hormone, which will stimulate 5 to 20 follicles. But that one follicle, which will be more sensitive to the FSH, will become the dominant follicle. Now, all these follicles will start releasing the estrogen. We see that estrogen levels is going to increase. We can see in the video as well. And here the FSH hormone is going to dip. Because of this, only one follicle will be dominant, while others are going to regress. Now, this continuous production of the estrogen is also going to help in the proliferation of the endometrium. Endometrium, we see that the cells are going to proliferate, glands are going to elongate. We see that the spiral arteries will also elongate. And this will compel, the estrogen will compel the LH surge. It will send a positive feedback. And this luteinizing hormone surge is responsible for the ovulation. We can see in this video as well that now this ovum, after ovulation, is traveling through the fallopian tube, and ovulation has taken place on the 14th day. Now, after this ovulation, this dominant follicle, that is the Graafian follicle, after the release of ovum, what it will become? It will become the corpus luteum. And it will start releasing progesterone, so its levels are going to increase as well. Now, this will be responsible for differentiation. The arteries are going to get coiled, more amount of it. If the fertilization is not taking place, then this corpus luteum is going to break down, and it will get converted into corpus albicans. And what we see here is that we need to understand this part in detail, that when there is no implantation taking place, there is no fertilization, this corpus luteum, it is going to get converted into corpus albicans, that is, it is going to break down, and then it will be shed off. Here we also saw in the graph itself that the levels of the estrogen and the progesterone dipped. And these estrogen and progesterone are actually responsible for maintaining the endometrial lining. So their lower levels will be responsible for shedding of this endometrium. Now let us talk about the hormonal regulation and the interplay. We know that the hypothalamus releases the gonadotropin releasing hormone. So in a female's life, at the age of 8 to 13, that is specifically the puberty, the hypothalamus starts releasing GnRH in a pulsatile manner. And this will actually trigger the anterior pituitary to start releasing the FSH and the LH, which will ultimately be responsible for the production of the progesterone and the estrogen from the granulosa cells and the progesterone from the theca interna, which is specifically the corpus luteum. So we'll be better able to understand this with the help of this picture. Here we see that in the menstrual phase, there is shedding taking place. But in this particular phase, that is from 5th day to 14th day, what we see here is that the levels of estradiol, that is the estrogen, there are 3 forms of estrogen. The one we are talking about in this image is the beta estradiol. So here we see that there is increased level of estradiol, which is from the dominating follicle itself. And because of this, there is going to be increase in the thickening, the proliferation of the smooth muscles are going to take place. From 1 millimeter of the thickness of the endometrium, it's going to increase to 3 to 5 millimeters. And after that, the ovulation has taken place. Now this corpus luteum, this corpus luteum, this will start releasing the progesterone. Its levels are going to increase. There is going to be differentiation and stabilization of the endometrium from the 15th to the 28th day in the secretory phase, and it's actually preparing the endometrium for the embryo if it is there, if the fertilization has taken place. But in this diagram, we see that if this particular woman, whose example we have taken, she is not having a baby, she is not pregnant. So this corpus luteum is going to get converted into corpus albicans. So there will be lower levels of progesterone and estrogen. We've already talked about the fact that progesterone and estrogen are actually involved in thickening and the proliferation of the endometrium. So the dipped level will again start another cycle, that is the menstrual phase. So this is basically the uterine cycle, which corresponds to the ovarian cycle. So now what are the imbalances of the factors which are taking place? So in a normal uterus, we know that there should be structural and hormonal balance. But if there is some kind of imbalance, we're specifically talking about the uterine fibroid imbalance, we see that in the hormones, there's 2 things which are taking place, which is the progesterone paradox and the estrogen dominance. We also see that in the structural aspect, we see that there is deposition of the ECM, excess materials in the extracellular matrix, and we see that there is reduced apoptosis. We'll talk about it in detail in just the coming slides. So now let's talk about the effects of structural imbalance. For this, first we need to understand in a fibroid uterus, there is a single cell. And that particular cell has somehow gotten mutated. How it has gotten mutated, again we'll see in the later slides. So now that mutated cell, it will have a property of reduced apoptosis. We know that there is a very important enzyme when we're talking about the process of apoptosis, that is capsase. So that capsase enzyme is lowered in that particular mutated cell. Now because of this, the fibroid cells, they'll escape the programmed cell death, and the old cells, the damaged cells, are going to survive longer, which will lead to this tumor mass formation, as we can see in this diagram. This one fibroid, this second fibroid, and this the third fibroid. So there are different types of fibroids. Now, another thing that's going to happen is the deposition of the extracellular matrix. We know that we need to have adequate amount of collagen, but if there is increased deposition, this mutated cell will have increased. It will have a property of increasing the deposition of components such as collagen, fibronectin, proteoglycans. All of this are going to increase the bulk of the uterus, and it will also store growth factors. So it will try to create the self-sustaining cycle. Now, what would be the effect of the hormonal imbalance? We saw that there's estrogen dominance and progesterone paradox. So before understanding this, let's just break down this phrase. Estrogen dominance. It means that this estrogen will be slightly higher in amount as compared to progesterone. That's why we are saying this estrogen dominance, and it is going to set the fire for the fibroid uterus. We see that estrogen is mainly involved in cell proliferation. We also saw in the normal cycle as well. So it is going to promote the smooth muscle proliferation, and it is also going to stimulate growth factor release such as IGF, TGF, beta, VEGF. Let's talk about them. So IGF is the insulin-like growth factor, so it will be involved in the cell proliferation. We see that there is TGF beta, which will be actually responsible for the fibroid, that is the transformation growth factor beta. Then we have the VEGF, which is the vascular endothelial growth factor, which will be providing blood supply to the uterus. Blood supply to the fibroid. Then we also have one more factor, which is the platelet-like growth factor that will be providing the angiogenesis to the fibroid. Now let's talk about the progesterone paradox. So progesterone paradox, it means that it is doing something which it is not supposed to do. So that's why we are saying it's paradoxical. So progesterone is mainly involved in the differentiation, but here it is not differentiating. It is inherently promoting the cell proliferation. How? By regulating the gene expression of the growth factors. There is also increment in the progesterone receptor levels in the fibroid, but not just the progesterone receptors. We'll see in the later slides also that there is increment in the hormone density of not just the ER receptors, but also the PR receptors. Now, what is fibroid uterus? Now, fibroid uterus is the most common benign solid tumor of the muscle wall of the uterus, specifically the myometrium. We see that it is monoclonal in origin. Monoclonal in origin, it means that a single cell is responsible for the formation of one particular fibroid. So for example, a female is suffering from more than one fibroid. Let's say she has 4 fibroids. So that one fibroid's origin would be different from the second fibroid, second would be different from the third would be different from the fourth. But the origin of that one particular fibroid, it will be common. It is pseudocapsulated, and it is mainly composed of smooth muscles and the fibrous connective tissue. There is deposition of the collagen, fibronectin, proteoglycans to increase the bulk of the uterus, the fibroid uterus. We have already talked about it. Now let's talk about the etiology of the fibroid uterus. Now there is some kind of mutation that is taking place. Either it's going to be a genetic mutation or it could be a chromosomal mutation. There could be MED12 mutation. This genetic mutation is mostly observed 70% of the time. Then we also see that there is HMG-A2 mutation and chromosomal mutation, trisomy chromosome of chromosome number 7. There could be also translocation of the chromosomes. So now we can see that there is some effect of this introduction of this MED12 mutation. Here is that the cell cycle has increased. We already talked about the fact that there would be reduced apoptosis, because of which they are going to create a self-sustaining cycle. We also see that the type 1 collagen production has also increased along with which is basically the deposition of the ECR. Now, what are the major differences between the normal uterus and the fibroid uterus? So, in this highlighted portion, these 4 parts we will discuss in them. So, first we have the extracellular matrix. In the normal uterus, there would be adequate levels of collagen. We see that in the fibroid uterus, there would be increased deposition of fibronectin, proteoglycans, collagen. Apoptosis is regulated in the normal uterus, but it is unregulated, which leads to the survival of these old damaged cells more in the fibroid uterus. We see that the hormone receptor density, there is an appropriate number of ER/PR receptors in the normal uterus, but in the fibroid uterus, there is increased ER/PR receptors. In the menstrual function, there is regular cycle and flow when we are talking about the normal uterus, but in the fibroid uterus, there is irregular cycle, there is menorrhagia. So why is it taking place? So there is a number of reasons why this menorrhagia is taking place. So first is because the surface area of the endometrium has increased. We can see here that the surface area is increased as compared to the normal one. There's one more point, which is the venous congestion, and also the fact that the spiral arteries, they become very susceptible to rupture because of the pressure surrounding the uterus. So to conclude and to summarize, we can say that the fibroid uterus, they are very common and they are benign in nature. Only less than 1%. So there is a very infinitesimal chances of it getting converted, these leiomyomas to get converted into sarcomatous structures. So we already talked about the fact that it could be the genetic mutation, it could be chromosomal mutation. The symptoms were mostly asymptomatic, like so said, and there's also going to be heavy bleeding in stages, and surgical intervention is also one of the part of the treatment. So thank you so much for your patient listening. May I now call Shreya Agrawal to carry forward the presentation. Thank you.
Good morning, respected dignitaries, esteemed faculty members, and my fellow colleagues. Today, I am Shreya Agrawal, and along with my team members, Rakshit, Khushi Soni, Skan Parekh, and Saumil Chaudhary, I am going to delve into benign lesions of uterus, focusing on fibroids under the moderatorship of Dr. Pradeep Suren sir and Dr. Swati Garg ma'am, Professor and Head of Department Gynecology. Let's take a quick look at major benign lesions of the uterus. Polyps. Polyps are the pedunculated tumors with prevalence of 20 to 40% of reproductive age women with abnormal uterine bleeding. Leiomyomas. Leiomyomas are benign neoplasm composed of smooth muscle originating from myometrium. They are highly prevalent with affecting almost 20 to 50% of women of reproductive age. They possess an outer tissue layer called false capsule which allow for easy shelling during surgery. Adenomyosis. Adenomyosis are ectopic rest of endometrial glands and stroma located deep within the myometrium. They are highly prevalent with prevalence of 12% to 34%. Endometrial hyperplasia. As the name suggests, it is abnormal thickening of endometrium with prevalence of 35%. Now, let's focus on polyps. Polyps are divided into different categories based on their origin. Endometrial polyps. Endometrial polyps are localized outgrowth of endometrium, composed of glands and stroma. Tamoxifen use during breast cancer can cause endometrial polyp. Endocervical polyp. As the name suggests, endocervical polyp are endocervical in origin. They are usually reddish, purple, and soft. Fibroid polyp. Fibroid polyp isn't a true polyp. Rather, it's an extruded submucous leiomyoma that has pushed through the cervical os. Placental polyp. Placental polyp is a retained bit of placental tissue adherent to uterine wall. They can cause secondary PPH or intermittent vaginal bleeding following an abortion or vaginal delivery. Next, let's transition to leiomyomas. Leiomyomas are benign smooth muscle neoplasms, typically originating from myometrium, derived from single progenitor myocyte. They are estrogen and progesterone sensitive. Next, as we know, growth of fibroids are multifactorial. Let's focus on risk factors associating fibroids. Early menarche. Early menarche is associated with prolonged exposure of estrogen, and estrogen promotes the growth of fibroids. Late menopause, nulliparity, increased BMI, polycystic ovarian syndrome, hyperestrogenic state, black ethnicity, high fat diet, and family history. They are all responsible for causing fibroid uterus. Next, let's talk about the protective factors. Protective factors include late menarche, multiparity, breastfeeding, menopause, combined oral contraceptive use, and smoking. Yes, smoking too, because nicotine inhibit the enzyme aromatase, which is responsible of conversion of androgen into estrogen, therefore decreasing overall estrogen in the body. Next, let's look fibroid classification based on anatomical location. Intramural, growth centered within the uterine walls. Subserosal, originate near the serosa, growth is directed forward. Submucosal, proximate to the endometrium, growing toward and bulging into the endometrial cavity. Last, cervical. Cervical develops outside the uterine corpus in the cervix.
Next, let's focus on the FIGO classification of fibroids. FIGO classification of fibroids is the universal system for anatomical description and is critical for clinical decision making and surgical planning. It uses a numerical scale from 0 to 8. Some mucosal types, type 0, type 1 and type 2. Type 0 is pedunculated intracavity lesion. Type 1 is submucosal with less than 50% intramural involution. Type 2 is also submucosal with more than 50% intramural involution. Next, other types include type 3, which is 100% intramural but still has contact with endometrium. Type 4 is 100% intramural. Type 5 is subserosal with 50% intramural. Type 6 is subserosal with less than 50% intramural. Type 7 is subserosal pedunculated. Type 8 is other, like cervical or parasitic. Now, we also have to focus on hybrid leiomyomas. In this, other types, we can see that it includes submucosal and subserosal, is that each with less than half the diameter in the endometrial and peritoneal cavities, respectively. Now, we have to take a closer look at submucosal leiomyomas, type 0, type 1 and type 2, because this helps us in evaluating surgical approach, especially hysteroscopic resection. These subtypes are classified numerically by their relationship to the endometrium. Type 0 has 100% of the mass within the uterine cavity. Type 1 has less than 50% of mass within the myometrium. Type 2 has more than 50% mass surrounded by a myometrium. Now, let's talk about some special anatomical and pathological variants of fibroids. Pedunculated subserosal. These are subserosal fibroid attached only by a stalk and is associated with a risk of torsion. That is, it undergoes rotation at its site of attachment to the uterus. As a result, veins are occluded and tumor becomes engulfed. Parasitic fibroid. Parasitic fibroid are also subserosal variants that detach from uterus and acquire vascular support from pelvic structures. They mimic DPL, as we will discuss later. Broad ligament fibroid. These are intramural fibroid pushed out between the layers of broad ligament. Pseudocervical fibroid arising from uterine body that occupies and distends the cervical canal. Lastly, stump, smooth muscle tumor of uncertain malignant potential. These are transition tumor between leiomyoma and leiomyosarcoma. To conclude, there are some rare infiltrative fibroid-like conditions like leiomyomatosis. These are extrauterine, benign, yet infiltrative smooth muscle tumors. Intravenous leiomyomatosis. These invade and extends into the vein, potentially reaching into the vena cava and cardiac chambers. Benign metastasizing leiomyomas. These are morphologically benign uterine leiomyomas that disseminate into the lungs. Lastly, let's talk about disseminated peritoneal leiomyomatosis. These are benign, multiple, small nodules growing over the peritoneal surfaces. Thank you. Now I would like to invite my fellow Rakshit to take it forward.
Thank you, Shreya. Good morning, Excellencies, respected faculty members and my fellow colleagues. This is Rakshit from MBBS 3rd Professional Part 2. I shall be discussing about the applied pathology and secondary changes of leiomyoma. So as discussed by the Department of Physiology, they explained you about the pathophysiology of the leiomyoma, but there are some novel approaches to treat and prevent leiomyoma. A modern and effective way to remove any unwanted proteins from the body is by blocking their activity through the development of immunobiological drugs that are based on humanized recombinant antibodies. So an experimental approach allowing for the selection of targets for the development of such antibodies is presented in this figure. So we can target at the level of the transcription, we can target single nucleotide proteins, we can target DNA, we can target the DNA or the misfolded proteins that has been created. So let's discuss about the secondary changes of the fibroids. One is the inadequate blood supply to the fibroid. Another one is the vascular thrombosis or infarction within the tumor. Next is the changes in the hormones during the state of pregnancy or after menopause. It could be the infection of the fibroids, particularly the submucosal type of fibroids. Now let's take a look over the certain types of secondary changes in the fibroid. Hyaline degeneration is the most common type of degeneration in leiomyomas. In this type, the smooth muscle is replaced by the fibrous connective tissue, as shown by this arrow here in this histopathological slide. The second is the dead degeneration that develops most frequently during the pregnancy. In this case, the myoma becomes tense, tender, and causes severe abdominal pain with constitutional upset and fever. Tumor assumes a peculiar purple-red color and develops fishy odor. This is a picture showing the degenerative changes which are very evident here in the center. The next is the cystic degeneration. It is an extreme sequel of edema as shown in this dissected specimen. They are the abdominal masses that mimic like an ovarian cyst, endometrioma and adenomyoma. Moving further, calcareous degeneration. These are caused by the deposition of phosphates and carbonates along the course of the vessels. These changes are generally found in older patients with long-standing myomas. This can be easily identified in the plain X-rays as shown in this radiogram. The last is the sarcomatous change. This is the malignant change in the myoma with an extremely rare incidence of around 0.5%. These changes are almost never seen in early reproductive age group, and that 0.5% incidence mainly includes the perimenopausal women. It appears hemorrhagic and yellow-gray in color. The consistency is soft and friable. Unlike leiomyoma and all the other type of secondary changes we have discussed so far, it is non-encapsulated and thus have a potential to spread via hematogenous routes. Now I would like to call Khushi to take the presentation forward. Thank you.
Good morning, respected dignitaries, esteemed faculty members, and my fellow colleagues. I am Khushi Soni, presenting this topic specifically focusing on clinical features, investigations, and management of fibroid uterus. Let's begin with the clinical features. It is important to emphasize that majority of the fibroids are asymptomatic, nearly 75%. However, when the symptoms do occur, it can significantly impact the patient's quality of life. The most common complaints include abnormal uterine bleeding, seen in 30% of the symptomatic women, typically manifest as menorrhagia and metrorrhagia. Dysmenorrhea, dyspareunia, subfertility, pressure symptoms. As the fibroid grows, it can exert pressure to the surrounding pelvic organs and leading to the symptoms related to bladder, ureter, and rectum. Recurrent pregnancy loss is also reported as miscarriage and preterm labor. Patient also complains of lower abdominal and pelvic pain. Now, infertility. Infertility in about 30% of women with fibroids are seen. The underlying mechanism may be uterine or tubal. In uterine, defective implantation occur due to congestion and dilatation of endometrial venous plexuses. It can also due to menorrhagia and dyspareunia. In tubal factors, mainly the size, the location of fibroid is important. If it is present near the junction of fallopian tube and uterus, cornual block can occur. Now coming to the signs, general examination reveals varying degree of pallor. Abdominal examination, a fibroid is typically palpable when the uterus is more than 12 weeks. It is firm in consistency, mobile, non-tender, margins well defined, and may be cystic. On percussion, it appears as a dull note. On pelvic examination, bimanual examination is performed to assess and confirm the uterine contour and size. Now coming to investigations and diagnosis. The first is transabdominal ultrasound and transvaginal ultrasound, the most important one. To confirm diagnosis and locate fibroids accurately, finding shows enlarged and distorted uterus, hypoechoic, heterogeneous. It also shows myoma location, size, number, and associated adnexal pathology. The second is three-dimensional ultrasound with color Doppler for accurate localization and to see the color flow for peripheral vascularization of fibroid. It helps in serial monitoring during conservative management. Third is saline infusion sonography. It detects submucous fibroids and polyp and useful when submucous lesion is suspected. Hysteroscopy is used for direct visualization, diagnosis and treat submucous fibroids. Next is hysterosalpingography. It detects the filling defect and confirms the cavity distortion by fibroid. MRI, magnetic resonance imaging, differentiates between adenomyosis and fibroids and helpful in fibroid mapping. It is more accurate and expensive. Laparoscopy is both diagnostic and therapeutic. It detects other causes of fertility like tubal patency, ovarian factors, etc. Uterine curettage, it detects coexisting endometrial pathology, and we do sampling of endometrial for histopathological examination. Now, these are some pictures of investigation that have been discussed. The first is the ultrasonographic view of fibroid. As you can see in the center, intramural fibroid is seen. The second is the magnetic resonance imaging of a fibroid arising from the body of uterus and present in the interior abdominal wall. The third is the hysteroscopic view of the submucous fibroid. Now, coming to the management. The management strategies depending on several key factors: the patient's age, the severity of symptoms, the size and location, and the most importantly, her future fertility desires. Treatment options may vary from medical, followed by minimal invasive procedures, followed by surgery. Now, based on symptoms, it could be asymptomatic and symptomatic. Coming to the asymptomatic fibroids, that management is typically expectant. Indications of expected management is when the uterine size is less than 12 weeks, the patient's ability to attend follow-up, and their overall compliance. We must remember that if the symptoms appear or it increases in size, the surgery is indicated. For the symptomatic fibroids, it includes two approaches: the medical management and the surgical management. For the medical management, our option is particularly for the young woman who desires future pregnancy. The goal of medical therapy is to correct anemia and improve menorrhagia before the surgery and to minimize the size and vascularity of the tumor in order to facilitate the surgery. Now, drugs for medical management. It has two options: the non-hormonal options and the hormonal options. Coming first to the non-hormonal drugs, the first is tranexamic acid. It is given 500 mg thrice a day and it has an antifibrinolytic action by reducing the blood loss. The second one is the prostaglandin synthetase inhibitor. Includes mefenamic acid 500 mg and NSAIDs. It relieves associated pain, no role in reducing the blood loss on either size. The third is aromatase inhibitor, given letrozole 5 mg once a day for 2 to 3 months. It prevents the conversion of androgen to estrogen, which eventually decreases the size of fibroid. Now, fourth is antiprogesterone, mifepristone, 25 mg given orally for 3 months. It also reduces the size and reducing the blood loss caused by the fibroids. Fifth is the GnRH agonist, leuprolide, 3.75 mg intramuscularly given once in every 4 weeks up to 3 to 6 months. It eventually leads to suppression of ovarian function, though as it is an agonist, it first stimulates, but later on, due to feedback mechanisms, it eventually suppresses the ovarian function, which decreases the fibroid size. Then GnRH antagonist, cetrorelix, 0.25 mg subcutaneous given, and it has also the same mechanism of action like GnRH agonist. The next is selective progesterone receptor modulator, SPRM, ulipristal 5 mg given once daily up to 3 months. It reduces blood loss and produces amenorrhea. Levonorgestrel intrauterine system contains 52 mg and releases 20 microgram per day for 5 years. It also reduces the blood loss and size. So the main thing is the medical management, the goal is to just reducing the blood loss and size of the uterus. Now, surgical management. Surgical pathway selected when the medical management fails or when the symptoms and size are severe. The major methods include myomectomy, that may be done by laparotomy, laparoscopy, hysteroscopy and robotic approach. Next is embolotherapy, laparoscopic uterine artery ligation, myolysis, endometrial ablation and hysterectomy. Now starting with myomectomy. It is an enucleation of myometa done for removal of fibroid while preserving the uterus and fertility. Indications of myomectomy. The key indication is in the woman of reproductive age desirous of pregnancy. It is also indicated for persistent uterine bleeding despite medical therapy and excessive pain or pressure symptoms, and when the size of uterus is more than 12 weeks. Now coming to the minimal invasive procedures, the first one is myolysis. The mechanism, it acts by destroying the fibroid via ultrasound, laser, cryotherapy or bipolar dichromy. The second one is radiofrequency ablation. It uses radiofrequency energy to heat and destroy the fibroid tissue, often done laparoscopically or transcervically. The third is magnetic resonance imaging, guided focused ultrasound. It causes thermal ablation and causes less pain than uterine artery embolization, discussing in the next slide. Other method includes uterine artery embolization. It causes avascular necrosis followed by shrinkage of fibroid. Mechanism, it acts, uterine arteries are occluded by injecting polyvinyl alcohol particles through percutaneous femoral catheterization. The second one is hysterectomy. It is defined as a surgical removal of uterus. It can be of different types: total hysterectomy, laparoscopic, abdominal, vaginal or robotic. Now, the summary and management protocol of uterine fibroids. So, on the basis of location, it could be in the body of the uterus or in the cervix, sex, cervical fibroids. In the body of uterus, we discussed based on symptoms. It could be symptomatic or asymptomatic. In the symptomatic, it could be done with medical management or surgical management. So, medical management, we have discussed all the drugs. In surgical, the main focus is on the myomectomy, hysterectomy, myolysis, including electrocautery, laser, cryo, and embolotherapy. In the asymptomatic patient, we do regular supervision in 6-month interval by serial ultrasonography when the size of uterus is less than 12 weeks and the diagnosis is certain. If in case the size increases or the symptoms appear later on, we go for surgery. If the size remains stationary, we go for follow-up by ultrasonography. If the size of the uterus increases by 12 weeks, or the diagnosis is uncertain, unexplained infertility and pedunculated fibroid is present, we go for surgical options. In cervical fibroids, it could be supravaginal or vaginal. In supravaginal, we go for myomectomy and hysterectomy, and in vaginal, we go for myomectomy and polypectomy. Thank you so much.